All right, I'm going to call the meeting to order. If you will please register your presence via the Granicus system. All right, there are 9 members present, 3 absent, so we have established a quorum. Next, I'm going to read the special call of the meeting. The Blount County Government Human Resources Committee will hold a special called meeting on Wednesday, January 2nd, 2019 at 5 p.m. in room 430 of the Blount County Courthouse, Maryville, Tennessee. The purpose of the meeting will be for setting the agenda, public input on items on the agenda, approval of minutes, financial reporting, update of open enrollment, specialty pharmacy vendor contract, amendment to Allegiance contract, discussion and action regarding Evergreen Solutions compensation plan recommended update, technical corrections to the employee handbook, and adjournment. We will now have the emergency announcement.
Before we get started, let me read the emergency evacuation procedures. In the event of an emergency evacuation, an alarm will sound. Everyone should exit the building by way of the nearest stairwell in a safe and effective manner. If the nearest stairwell is blocked by smoke, use the other stairwell. Do not use the elevator. Once you have reached the main floor, follow the exit signs to exit the building and quickly proceed away from the building. Please be mindful of others evacuating and of emergency vehicles.
All right, the next item is the setting of the agenda. We're going to remove item G, so the chair will stand for a motion to set the agenda while removing item G. So moved. We have a motion by Commissioner Hammondtree. Is there a second? Second by Mr. Hedrick. Is there any discussion? All right, if the members are ready for the question, we will now take a vote on setting the agenda with removing item G. All right, that motion passes with 10 yes votes, 0 no votes, and 0 abstentions. We will now have public input on items on the agenda. Is there any public input on items on the agenda? Seeing none, we will move on to the next item, which is item C, approval of the minutes. The chair will stand for a motion to approve the minutes. Moved by Commissioner Hammondtree. Is there a second? Second by Ms. Crisp. Is there any discussion on approval of the minutes? Seeing none, please vote on the approval of the minutes. All right, that motion passes with 10 yes votes. We will now move on to item D, which is financial reporting. We'll recognize Ms. Angeli to come up to the podium and present our financial report for information only. Let me get the podium. All right.
Sorry, that's news to me that I was presenting, but I do have it here. Dina wasn't able to be here tonight, but this just shows the revenues versus the expenditures for the health fund January through June of 2008, which was last budget year, and then July through November of this current budget year. One thing to note is that on October and November, you can see that medical claims started increasing, and that's the first 2 months that expenses exceeded revenues. So that's something we'll keep our eyes on going forward. So,
All right, are there any questions? All right, thank you.
all right, welcome.
We'll move on to item E, which is the update on open enrollment. The chair is going to recognize Cole Harris to present on this item.
Not that one. Thank you. All right. So with this presentation, it's going to be brief, just to give you a recap of how open enrollment looked. Since we had a new vendor this year, I want to make sure I've got the... Yeah, thank you, Lisa. I guess you'll have to do it. Oh, maybe that's why it's frozen. Okay. I wonder if it'll work now. Oh, yeah, it works now. Okay. So we're just going to go briefly through the logistics with the US ABLE enrollers and then the enrollment count so you can see how they did. For those that are directly involved with employees or experienced it yourselves, I'd be happy to hear any feedback that you have on it. But from what I understand, compared to years past, we personally did not receive any complaints from the enrollers, whereas the few years prior, we usually had at least a couple complaints of, an enroller may not give the correct answer or just not as good of an enroller, whereas from what I've heard, it's been nothing but pretty good reviews from the US ABLE. So they were able to provide substitute teachers for those that were needing to leave their classroom to make enrollment. I think what was very successful this year is the US ABLE team met with the principals prior to the enrollment to put together a schedule and be able to, I think, create better expectations as to how the enrollment would look. And we had very, very positive feedback from the folks. Any feedback that we received was so far fairly positive. I don't know, David, if you've heard any kind of, okay, perfect. As far as enrollment counts, the enrollment for the medical, and it was slightly down in certain aspects and then up in a few others. So in the medical, dental, and vision, you can see it's fairly close to where it was. And this is just through the counts. This is not going to include the retirees. So it'll at first glance, it looks like it's off by a couple hundred. That's because the retirees are not included. So if you add the retirees back in, you're right around where they were at previously. Dental, pretty much the same. Medical, the same. Vision, pretty much same. So then we get into some of the optional coverages, and this is where I think there's better explanation as to how it works. We saw an improvement in the short-term and long-term disability, which is great for you all. So the employees are able to continue their salary. Is a true open enrollment, meaning that they didn't have to fill out evidence of insurability. So it's good that we had an uptick in enrollment for that, so that wasn't missed. We had an increase in optional life insurance enrollment. The convenient care went down slightly, but we've gotten good utilization out of that for those that have used it and who are enrolled. The accident may remain basically the same. You'll notice the critical care and cancer and the cancer are dramatically different. So then obviously that pops out and says, why is it so different? The main reason for that is under the Colonial product, the critical illness policy didn't have a cancer component. So if you wanted cancer, you had to get the critical illness and then a cancer benefit separate. With the US Able product, it does include cancer. So it's a better buy to get the critical illness with the cancer. And then you saw a dramatic reduction in the cancer benefit. So it just overall makes more financial sense to it from that perspective. And then with the hospital indemnity, that's a new product. We had 22 enroll in that, which we kind of expected that it probably wouldn't have much. That's to cover deductible type expenses, but at least it's available for those that wanted it. So I was asked earlier on the BMI side with the interactive health. That was where earlier in the year we had folks come and do a health screening at the different locations. The response I received was around 20 participated, is that right, for that. So if you recall, in previous years when we got that put in place, we couldn't get an incentive passed for participating in a BMI, which means that if you participate, that maybe your premiums are different than those that don't participate. And that's where a nurse comes on site, does a blood draw, tells you basically if you have any health conditions. So we had a relatively low or very low turnout at 20, but probably even more than I was expecting with there being no incentive for folks to do it. So that's something that we can look at in the future years as well. Any questions or concerns? Awesome.
Any questions? All right, thank you, Cole.
Mm-hmm.
You can stay right there, actually. We'll now move on to item F, which is the specialty pharmacy vendor contract. This is discussion only, and I'm going to recognize Cole Harris again to talk about this one.
Okay, great, thank you. All right, so what we're going to get into today is on patient advocacy programs, and this is something that we're using as a way to give you information for what we inevitably will face as a big company, essentially is what you are. You have over 3,000 members, and it's inevitable at some point come across things that we have to deal with. The pharmacy trends have been staggering. We've all talked about the pharmacy over the last 6 months and ad nauseum probably, but what this is referring to is going to be the high cost drugs that you haven't even seen yet. And so what you may or may not know, we all know that prescription costs can be high, but what these specific set of drugs, it's unbelievable how expensive they can be. They're in excess of $100,000 per dose. There's a medication coming out that, if approved by the FDA, could exceed $1.7 million per use. And so these are areas that your plan are exposed to right now. And so we want to look at ways of how do we deal with this? I mean, are we going to deal with our plan getting hit with $1 million+ a year for one medication? So we've been at CBiz, we've been researching various solutions. There's some new entities that are out there that are working to try to combat these potential issues. So I want to provide you the information as something that you can start thinking on, and hopefully we'll have a set of vendors to present to you in April's meeting, if it makes sense to move forward in that direction. So with the expanded medication classifications, and it really hits those rare disorders, autoimmune type disorders, just very limited resources out there. So they're just incredibly costly. So What we're looking at is this is an alternate funding type of model. The issue that you all are inevitably facing is Medicare price pivots on the list price. So right now you have a manufacturer that if they want to give you a reduced cost, inevitably that impacts their Medicaid and Medicare pricing with the government. So they can't. Fiscally, they can't. If they're to do that with you all, then they'd have to do that to their largest customer. And their contract with Medicaid is they have to give them the lowest price. So if they reduce it for Blount County even, that means that you all have they will have a much lower price. So their solution to this is they've founded corporate social responsibility programs, or CSR programs. And the thought behind these programs is the manufacturers are funding these foundations of sorts that then entities can dip into should they come across this, if they qualify. So the CSR may include a private public charity, state, county, municipal type programs, and other foundations. The vendor that we're discussing in reference for today doesn't really get into the charity type side. That's where I think there could be some compliance type issues. But these CSRs may provide product or copay assistance. So the funding is not specifically designed, those programs aren't designed for the indigent, so it's not meant saying that it's only available for those who can't afford their own medication. Those fundings are earmarked for the patient and not the sponsor. So the way that sponsors are having to do this is essentially saying we don't cover the medication, right? A patient who is underinsured will then have access to these funds. So right now, the way it works, even with something like a higher cost drug, like you can have some drugs that are $5,000, $6,000, like cancer drugs per month. Currently, the patient, if those costs go towards their deductible, the manufacturer can cover those portions of the cost. So you'll find that, for the plan sponsor, it may cost $100,000, but to the patient, they may have a $3,000 deductible. So it makes sense for the manufacturer to say, we'll cover that $3,000 so you can get your drug, because of course they're getting their $97,000 from the plan sponsor. So this program is kind of set up so that it helps protect the employer as well. Because inevitably what would happen is if that person didn't have that drug covered by the employer, that's where this advocacy program comes in, and they will go and find the foundations that are available to help cover the cost of that drug. And most times that drug cost is covered in its full entirety. So then you look at Blount County not paying any costs and the patient not paying any cost for it. So the plan change has the effect of excluding the drugs from the plan coverage. The impacted member, if there was an impacted member, would then reach out to this separate vendor who would then work to find the foundation that would fit the need for that particular prescription and then walk them through all the steps that they need to do. They would have to complete a full enrollment form, send out personal health and financial information to the advocacy program as that is required. Even though that doesn't disqualify them based on financial, they still require that information as part of their step. And then, as mentioned, the member would still receive their drug, many times at no cost to them. The impact to the plan is, again, you're essentially pushing that expense onto the member, which then the member goes to the CSR to pick up the cost, all right? I know this is kind of a lot of moving parts and a little confusing, so please feel free to stop me with questions. The plan would have a contingency in place to where if for some reason that CSR wasn't able to find or secure finances for that prescription, then we'd go back to the plan and amend the contract to get it recovered under the contract. So the member would not go without having the medication. The financial impact, as mentioned, there's the extreme drug costs that are in excess of $500,000 a year. Those are rare diseases, usually less than 0.1% of your fills. But if you did need this, it'd be an extraordinary amount of savings. The cost with this particular vendor was $4.67 per employee per month to cover it, and they wouldn't start that cost until they actually had a patient with you where they needed it. So if you think about it, if you had a drug cost that was like $500,000 or more, and they're able to wipe that completely off, there's a cost to do that, obviously. If you look at $4.67 amongst all of your employees, you're looking around $80,000 a year. So it more than pays for itself in that part. They can go even broader and do a specialty drug, and this is where all of the other vendors typically go into play, is they can go down to your higher cost drugs like your Humiras of the world or Enbrels, your $5,000, $6,000 a month drugs. They're more prominent. You all would have some in your environment. That cost is $13.50 per employee per month. And then they can even go down as far as diabetic type medications, which you'd find a lot more disruption. It's a lot more comprehensive. By no means would we recommend it just yet, but just want to let you know these programs are out there. When you get into that second and third bullet point program, you'll see here that it would require using a new PBM partner, because your contract with Caremark says you can't exclude specialty drugs and have it to where it's covered by another vendor. So we'd have to use a different PBM at that point if we went down that route. The first option is not even filled through the Caremark, it's filled through your medical plan. So it wouldn't impact your PBM status. Savings could range $500 to $1,100 per employee per year for the second to third tier. So you look at over roughly 2,000 employees, that'll give you a good idea of the overall cost savings from that side of it. Some concerns, just so you have full understanding of everything that's out there. When talk about the good parts and the bad parts, or the concern parts. The member disruption, there would obviously be disruption because it's a new way of doing business. It's a new way of getting your drug for those high cost drugs. Again, keep in mind the member impact level is very minimal across your employee base, but it could happen. You may have 1 or 2 or 3 or 4, or if you go with the second bullet point, it could be 100 or more. But they'd have to learn it's a new way. They don't just go and get their drug from, usually those are going to be mail orders, so you don't typically see this impacting even a local pharmacy. It would be more of those specialty medications that are filled through specialty pharmacies. The long-term viability, this is so new as far as a solution. We don't know how long this will be around. I mean, it could be a 1 to 3 year solution, or it could be indefinitely. But there's just uncertainty around it. And the advantage to that is uncertainty, we can get around that because we just fix it if something were to happen at that point. Stop loss would be a concern of if we amend your plan contract to say that these drugs are excluded and then all of a sudden we build them back into your plan, it's possible that the stop loss vendor doesn't cover it because the stop loss contract is based on your plan not covering it. So that is a potential concern. And then legal validation, obviously we'll want to make sure that we do it so that it's not considered profiling any specific individuals. And obviously, as mentioned, we don't want to be considered where we're taking from a charity erroneously, which obviously we wouldn't put you in that position from that side of it. So I know it's a lot of information really quick, but it is a concern that we're facing on a global level with a lot of our clients on a national perspective. These are things that you're going to start hearing more of. And I think given your size, and we're going to be speaking to all of our large clients about these types of programs, we wanted to get this in front of you so we're not trying to chase a tail further down the road, and get ahead of it and talk through this and give you this information. So, questions?
When we're talking the 467 to 16 per employee, that's not just the employees that are on the specialty drugs, that's per employee in the system, correct?
Correct.
When you're talking these new drugs that are hitting the market for hundreds of thousands of dollars, one you said was $1 million, when these drugs hit the market, why do they charge $500,000 or for whatever, or hundreds of thousands of dollars per dose when you're going to have multiple doses? How does the pharmaceuticals, why are they charging that kind of money for a drug that they're in the healthcare business, they're supposedly in the business to find solutions to save lives? Mm-hmm. You hope to God that they're doing it because they have a calling to do that. Why are they charging hundreds of thousands of dollars for these drugs that they're manufacturing? And they can, once they get the formula and the chemical formula right, they can mass produce these drugs. Mm-hmm. Why are they charging that much money?
So I think that's a great question, and I've been trying to research that side of it, and we've talked about it internally quite a bit, and I think it's a topic on a national scope as well. But what I've been able to come up with is, one, we're subsidizing Medicare and Medicaid, so that's a part of it. Two is going to be and this is, I think, the most important part, is whenever they release the drug, if you look at pharmaceutical manufacturers, almost all of them are going to be publicly traded. And so they give a number to their investors as to target revenue goal annualized for that particular prescription. And when you look at some of these conditions, I was looking at it earlier, there's some of them there's only 8,000 people across the world that may have some of these conditions. Some of them are 500 people in the United States. So, I mean, there's so few amount of people. And if they have to hit a target goal of $50 million over the course of the year, I mean, do the math, you've got to have a really high cost for that prescription. Otherwise, it's not worth their time to go through the R&D process and go down that path. Obviously, you're talking about money with people's lives and that at stake. When you move outside the U.S., you'll see that obviously we're paying prices that are much higher than any other country in the world. So we're also subsidizing those costs as well. So.
And I understand if you're making a commodity that is being sold out here, then you're trying to meet the expectations of your investors. I understand that. But when you're developing a chemical or a drug that's saving lives, how does that, I don't understand how that plays into the same playing field as someone that's saying, if you'll invest here, we're going to make this product and we're going to sell enough of them to where we're going to give you this return on your investment. When you're playing with people's lives, as the pharmaceutical companies are, that doesn't seem like that should be on the same. And I understand capitalism is capitalism, and I understand how it works, and it's worked great. But I don't understand how the pharmaceutical companies can hold these people that are dying hostage with a drug with hundreds of thousands of dollars to $1 million because they're trying to meet investors' demands. To me, there's something wrong morally with that, and ethically, if you want to know the truth about the matter. I don't think that those are two things that they shouldn't be on the same. You shouldn't be doing that with something that's the difference between a child or an individual's life and a commodity that you're selling out here to the public for whatever reason.
There's and I wish I knew exactly or I could remember the name of the prescription, but there was an article that discusses just that about a week ago. It was out, there was a medication that's been around since the 80s, but the company never went through all of the processes to get it approved fully by the FDA, so they're only in status by considered experimental. And they just gave the medication away to those that needed this particular drug, and it was for a debilitating disorder that they had. Well, there was a company that took over the rights of that formula for that medication in 2010, and then they went through the steps to go through the FDA, and they got it approved through the FDA and are now charging those patients over $100,000 per dose. So same thing. I mean, whenever that's the unfortunate part about this industry is it's a racket.
I don't necessarily think that getting the Senate or the Congress in Washington involved actually helps anything. And obviously, getting them involved in this is probably not going to happen. They probably are involved in this, but probably wouldn't want to know how they were involved in this, to be honest with you, for them to be able to charge those kind of prices. The next question I have, if I may, Mr. Chair, we're self-insured. We get a $500,000 drug that is needed, $700,000 drug, 2 doses a month. You know, in less than 6 months, our fund is going to be broke. We're going to deplete our insurance fund. What we're looking at here is we're going to work on putting a program in place, and I guess we'll come back in January or July, because we need to get ahead of this before it gets ahead of us. And so what is your plan is to research this and come back to us, because we're going to need it before the budget, correct?
So April.
April, okay.
Yeah, so our plan, our pharmacy team has been working tirelessly on this effort over the last month and a half. We've also involved our legal team and to make sure we have all the nuts and bolts as much as we can, at least with their opinion around it. And we've been looking at other vendors as well, so we can come up with a solution that best fits your needs. The issue that we're coming across with some of the other vendors that we've located, while they may be more sophisticated in how far along they've come in this process, the way they charge is a lot of them charge a percentage of savings as their cost. So you imagine if they're saving you $1 million a year, a percentage of savings could be still horrific compared to the per employee per month. So we're trying to find a solution that best fits Blount County's needs for the future going forward. So my goal is to have some of that data to you by April's meeting.
All right, Commissioner Crowe?
Just to follow up, to get that on the budget, and we just get it in April, can CBIZ not come up with a possible solution quicker than April and have us look at it? Because implementation is going to be a big deal. There's even the thought in my head of when you lay something like this out to your employees, it would be nice to educate them and let them have a voice, because this is basically socialism and insurance. So I'm thinking, if you're going to do something like that, rather than this committee sitting here and deciding who gets treatment and who doesn't, and I like the fact that there's a contingency built in for if this charity company won't pick it up, then we're not just going to leave you hanging. But this is pretty big stuff, and Dodd Crow don't want to be the person who decides if somebody lives and dies. I would like some buy-in from our employees. So I'm thinking, I don't believe it would take all the way to April for y'all to come back with a possible suggestion. We know we got to do something. That's pretty clear. So I'm asking advice from the rest of the committee and from you. Do we have to wait that long? Thank you, Mr. Chairman.
Thank you. Anyone else have any questions or wish to speak?
I think they're trying to figure out when we do need it.
Ms. Johnson?
Thank you. In April, what we would be doing would be bringing a contract from one of these companies to have the committee approve. We wouldn't necessarily be saying what drugs would or would not be approved. We would just be contracting with a company who could help us save on these super high-cost medications.
All right, any other questions or discussion? Commissioner Crowe?
Does that mean it's too late for us to do something currently because we're already into a contract?
You know what I mean?
Yeah.
No, it's not too late to do that. The only part that may be too late would be on if it requires changing PBMs. And at that point, we would just have to do it for January of 2020 for that part of it. But if it doesn't require changing PBMs, we can put that in place at any point.
So I'd like to go back to this group and say, hey, am I the only one that sees this as a more urgent need, or am I just panicking? Because what if somebody gets tomorrow, they become one of these people?
Mm-hmm.
Our fund is in trouble way before April.
What do you say, Carl?
Yeah, we said April just because that's the next meeting on the books. We can be ready probably by the end of February with, or potentially earlier, depending on our team.
I mean, how much time do you need your dates for? You tell us.
Yeah, so I mean, I would, we have a pretty good head start on it, but I would still feel more comfortable if we had about another 4 weeks or so to keep doing our due diligence. So by the middle of February, I think we could have some solutions we could bring to the table.
Mayor Mitchell?
One of the issues, and Cole, I'm not trying to speak for you on this, this is all relatively very, very new, is it not? As a matter of fact, we're probably the first ones that have even brought this to you and talked to you about this as far as starting a process of getting us some type of a safety net on this, correct?
We've been researching this for about 3 months. You all would be our first client nationally on it. So that gives
With that in mind, I don't want you to take anything away from what you're going to find out that you can do for us that is going to benefit us, the very best. I want the very best benefit option that's going to be offered. Can you make that happen? And how long is it going to take you all to do the due diligence, look at the legal ramifications of it? Because there is a lot of legal ramifications in this, is there not? Mm-hmm. How long is it going to take you to make that happen to where you can feel comfortable standing right there and coming back to us and not letting us make a decision or start talking about the process?
I think I'll be much further along to where we could get to the next step, or at least have more conversations within 4 weeks.
4 weeks? Can we have a special call meeting, I guess, if we have to do that? If you come back and you're ready.
Yeah, I can call a special meeting, or we'll follow the process.
Then I think you need to be in conversation with Jacqueline, and when you're comfortable and your company's comfortable with coming back to us with what you see as a outcome that's going to be favorable to this county and our employees as well as our citizens, then I think then we can do a special call meeting then. Okay. If that's okay with this. I'm just saying for the committee.
That works.
All right. Mr. Hedrick?
Go ahead. Can we go ahead and put that in a motion? Make a motion for a call meeting in 4 weeks.
I think I can just call it, correct, as the chairman? All right.
Is that good?
Should we go ahead and check dates? All right.
Yeah, I'll talk to my pharmacist today after this meeting and make sure that I didn't write a check that he couldn't cash.
Yes, absolutely.
Yeah.
All right. Then we will check on that, and we'll coordinate on a special called meeting.
Yeah.
All right, any other questions or discussion? Yes, thank you, Mr. Harris.
Thank you, guys.
All right. We will now move on to item H, which is discussion and action regarding Evergreen Solutions compensation plan and recommended update. The chair is recognizing Jacqueline Johnson to present this item.
All right. As you guys know, Blount County contracted with Evergreen Solutions in 2014 for the classification and compensation study. And at that time, one of their recommendations was to have an updated compensation study done every 3 to 5 years. So following that guidance in late 2017, Blount County requested an update to the study and again contracted with Evergreen Solutions to perform that study for us. So Evergreen analyzed both our current salary system, the one that was put in place in 2014, and the market competitiveness of our plan. And from that information, they developed a recommendation for a new pay plan and a recommendation to implement that plan. And you guys would find the draft report in your meeting packets for our meeting today. But the super condensed version of that full report is that the salary survey results showed that the county's current pay plans lagged the market for our desired market position for the 65th percentile for general county and 75th percentile for post-certified sheriff's deputies, which indicated a need for the development of a new plan. So Evergreen developed a new step-based plan with 2.5% incremental steps that aligned us with our market position, and then helped develop a recommendation to implement that plan, taking into account tenure, which we have not done in the past. So with the support of this committee, we're asking that we can pass this on to full commission, and that we to fulfill our commitment to have the plan reviewed periodically. And if approved, we'll use this plan, this updated plan, as the calculus to determine the budget for the 1920 budget year, and would implement in July of 2019.
All right, thank you. Before we have discussion and questions, let's have a motion to approve and forward to the commission workshop, and then we'll have a second, and then we'll go into discussion and questions. Is there a motion to approve the draft resolution and forward it? Moved by Commissioner Hammondtree. Is there a second? Second by Mayor Mitchell. Now we will have discussion or questions. Please press your button if you wish to speak. Commissioner Stinnett, you are recognized.
Yes, I have concern the fact that we created Evergreen to make sure that all our departments on the same level ground, and that we all use the same guidelines. And from what I understand, we're going to have two different. We're going to go 75. For the sheriff's department people, and 65 for the uncertified folks. And I just, we have folks that they start work here at Blount County and making $11 an hour. And so, I'd like to talk about, or even make a motion that everyone goes 75. We take them to 75. That would cost us $375,000 just to take every department to the same level. So before I make a motion, if somebody else would like to jump in there and talk about it, that would be fine. Somebody may have some arguments that might change my mind. Thank you, Chairman.
All right, thank you, Commissioner. Next, I'm going to recognize Commissioner Hammondtree to speak.
Thank you, Mr. Chairman. I've worked for governmental agencies at all levels. Some raises were given at the whim of whoever was at the top. Others gave a percentage, which widened the gap between the highest people and the lowest people. And we need to set up something where a certain position makes this to start out, And every year, they get an increase based on the number of years. The best I've ever worked under was in the military. Your rank and number of years determined exactly what you were going to make, and you knew that. There were no bonuses, no raises. You knew when you got 10 years as a lieutenant, which hopefully you wouldn't be 10 years as a lieutenant, but anyway, you knew exactly what you were going to make. Thank you, Mr. Chairman.
Thank you. Others wishing to speak? Commissioner Crowe, you're recognized.
I share Commissioner Stennett's concerns, and I'm trying to figure out, okay, should the market drive it, or should equity drive it? And it sounds like we came up with a plan, or we looked at a plan, or we was presented with a plan because we're losing that particular group. And we want to retain that particular group. And I'm like Commissioner Stennett, I need more proof to say, hey, let's step out and let's give these people this much and the rest of the employees this much. It doesn't seem equitable when you're trying to create an equitable plan. So I too have the concern of why, I know it's market driven, but still why you would go 75 for one group and 65 for the other group. It makes one group seem like they're less valued.
Others wishing to speak? Commissioner Crowe?
Was the figure correct that to increase everybody to the same would be $350,000?
Do we have someone present who can speak to that? Ms. Johnson?
The difference between the total cost of doing 65 and 75 and doing all employees at 75,000, or at 75% was around $375,000.
Others wishing to speak? Mr. Hedrick, you're recognized.
I agree. I see Commissioner Stennett's point, Commissioner Crowe's point. However, our officers are grossly underpaid for what they do, and they deserve every extra penny we can get them. But as an overall group and team, I think we might be sending possibly a wrong message of importance across the board. Everybody here is important. And to single it out, you're 60 and you're 75%, I think that might be a wrong message, but I don't want to discount what our officers get because they deserve it. So I think we need to look at it and make sure we make the right move.
All right, thank you. Commissioner Carver, you're recognized.
Now, I understand this was just a one-time restructure to get everybody in place, and then everyone would fall into the same role. Is that correct?
That is correct. So initially, July 2019, we would be getting all of the employees on the scale. Beyond that point, each year we would have 2.5% incremental increases for each step.
Anyone else wishing to speak? All right, Commissioner Stennett, you're recognized.
Chairman, I'll make a motion that we change the recommendation and put everyone at 75%.
All right, there is a motion on the floor to amend the proposed course of action to have everyone at 75%. One moment, we'll have a motion on the screen in a moment. Certainly. Commissioner Crowe, you're recognized.
Yes, Mayor, if you could help me here, because in talks before, maybe we need to direct, I'll ask the chairman and you ask if you need to. But I remember conversations where since 2008, we have cut X amount of employees. I would like to know somewhere that figure, my thought process is, if you're losing employees and other people's having to pick up the workload, and I know we've gained a few back, but it would make sense that you would pay the employees that picked up the workload a little more. So when I get calls about my vote tonight, I would like to have that figure handy if you got somebody who could answer that.
All right, before we do that, who seconded Commissioner Stennett's motion? Commissioner Crowe? All right, so now we're on the amendment. Is there anyone present who can speak to Commissioner Crowe's question, or who wishes to? Mayor Mitchell, you're recognized.
8 years ago, I'm going on 9 years ago, when I was elected as the mayor, the way that we paid our employees had no structure whatsoever. There was no structure as to how you paid your employees. Your employees were paid based on, I have no idea. I don't even want to go down that road. But we worked very diligently to get this evergreen study in place. It was the buy-in from all the elected officials other than one. Now it is the buy-in of all of our elected officials. We've been able to give our employees a structure that is the same type of structure you see in the business world out here. They don't just get a raise every year. They have to maintain a performance evaluation. They have to maintain performance standards to get the raise. Going back over this 3 years, have we lost some employees? We did. Initially, we did reduce quite a bit of our employees. But with the growth of this county, and I'm not going to say that we're still at a reduction. I probably are reducing. We have reduced our employees some as far as numbers. I know that the highway department has. I know my office has. I know that Phyllis and Scott are working at the same amount or less than we did 8 years ago, 9 years ago. And I understand you're saying. Making the comment we're not being fair to our employees. Well, I disagree. I think we've been very fair because I think we appreciate our employees. I think getting the evergreen in here, getting that study done, getting our employees up to a standard where they get a cost of living, where they get a step raise a year, and actually putting them at a level that is comparable to the market out here in this county has been very, very, it's been groundbreaking for a county to be able to do this. And when we're talking the 65%, 75%, we're talking 65% for the employees and 75% for our post-certified deputies, which is about 150. The reason that is because they were so far back behind the 8 ball on this that we're just now trying to get them caught up as those post-certified deputies out there. That's the reason the 75%. It's not us trying to be unfair to the employees. It's not for us to say, well, we're going to differentiate from you, because I respect and value every one of these employees. And to say, well, we're going to bring everybody up to the 75% because we're doing these 150 post-certified officers, and it's going to cost $375,000. Well, guess what? That's a penny on the tax rate out here. And in this whole thing that we've done with this evergreen, we've had the support of this county. We've had the support of these citizens that pay the taxes every day. And I think we need to respect that, and I think we need to do due diligence when we make these decisions to make the right decisions, to where they have the trust and the faith in us that we're doing the right thing. Not just on a whim decided everybody deserves 75% and it's going to cost a penny on the tax rate. So in my opinion, I think the 65% on the evergreen for our employees with the 2.5% step raise and recognizing their tenure and giving our deputies the 75% on the post-certified is absolutely fair. It's fair to our employees and it's fair to our citizens. That's what I'll have to say about it.
All right. We are going to have to take these votes pretty soon. We're going to have to recess the meeting because there is an insurance committee meeting right after this. But I'm going to recognize Ms. Johnson.
Thank you. I just want to be clear on this. So you had asked the difference in the cost for having the 65th percentile for general employees and the 75th percentile for post-certified, and then moving all employees to the 75th percentile was a cost of $375,000. And that is the case, but that's salary only. So taxes on that are going to be about $57,000. So really the total cost for salary and benefits is going to be closer to $437,000.
All right, thank you. Mr. Hedrick, you're recognized.
Just one quick clarification, which makes a huge difference. If indeed and in fact this gets the officers where they should be, it gets them caught up, then that's great, because they should be. And if it's continuing, the rest of the employees, that's whatever, 65, I feel like we've probably got them going on the right path to where they need to be. However, the officers were way behind. So is that the clarification? That gets the officers finally where they should be?
All right, Mr. Stinnett, you're recognized, and then we'll probably need to recess.
The 75 says that there's, what that says is that Maryville and Alcoa can still cherry pick them away because they're still 25% behind what the other agencies are being paid, what we're comparing them to. Same thing with the 65%. The 65% says that they're being, they're ranked 65th in the comparison of the study. So, is our officers where they need to be? No. We're still going to be cherry-picked. We're still going to lose officers to Maryville City, to Alcoa City, to Oak Ridge, and we're going to still lose other employees. And again, I'd like to refer back to the fact that the reason we did Evergreen was to get everyone heading the same direction and get everyone on the same scale. And I forgot what else I was going to say, Chairman. Thank you.
All right, Ms. Johnson, you're recognized.
I just want to clarify. So what it means to be at the 65th percent of market means that our salary ranges would be higher than 65% of our peers. Just wanted to clarify that.
Which is better than we were by far.
All right. Oh, go ahead.
That's correct. So the last time we did the study, our market position, we wanted to be at the 60th percentile of market. Over time, we've fallen behind because our peers have changed their pay practices, and this time we had different respondents than we had the first time around. So we're trying not to only get back up to the 60th percentile, which we were at the first time we had the study done, but to do a little bit better and get to the 65th percentile of market.
All right, thank you. Commissioner Crowe, you are recognized.
Still working on clarification, because that's where I started on this, and that is, and I should know this, but it's been several weeks since we had our meeting. So once we make this move, all we're doing is getting it up here, and then there's no 75, 65%. All we're doing is making a move. And then next year, it's the same 2.5 for everybody. Is that correct?
Yeah, so the 65th percent of market is what they use to set our salary ranges. So our salary ranges are now at the 65th percentile of market. What we're trying to do now is to implement, we need to approve the salary ranges, or the pay plan, and then to implement, we are going to take into account tenure and have the employees placed inside the plan for this year only. And then moving forward, in the years to come, we would increase salaries on a 2.5 incremental increase, which would be a step.
We'll make sure I got it correctly, okay? So if I run into an employee that is not post-certified sheriff's office, I'm going to say see if I'm telling the truth, we had to adjust the market to be able, hopefully, to retain our people that we have trained. So that's why we did this. This is not a forever thing. This was just trying to pull up this particular group of employees because they were terribly below market. Would I be telling them the truth?
Yes, so basically we're going to have two separate pay plans. One is a step plan for the 65th percentile, and another one for the post-certified employees, just like you said. But at the minimum, the minimums of the two pay plans will start at different places. The 75th percentile will start at a higher figure, at a higher salary.
All right. Any other questions or debate? All right, seeing no lights, we're going to vote twice. The first vote is going to be on the amendment to bring everyone to 75th percentile. And then the next vote is we're going to vote on the main motion, which is to send the whole thing on to commission workshop. So if you're in favor of the amendment, which is moving everyone to 75th percentile increase level, vote yes. If you're not in favor of the amendment, vote no. Mr. Hedrick, do you wish to vote? All right, the motion to amend fails with 1 yes vote and 8 no votes. Now we are back to debate on the main motion, which is to forward the whole thing on to commission workshop. Is there any debate on the main motion? Seeing none, we will call the vote on the main motion, unamended, to forward it to the commission workshop. So please vote yes if you're in favor of the main motion. Please vote no if you are not. All right, everyone, please vote. That motion passes with 9 yes votes, 0 no votes, and 0 abstentions, so that item is forwarded to the commission workshop. Next item on the agenda is technical corrections to the employee handbook. I will recognize Jacqueline Johnson to present this item.
Thank you. The Blount County Government Handbook refers to the 6-month period of time after a hire as both the introductory period and as a probationary period. So to create consistency across the handbook, we're asking to use the term introductory period throughout.
All right, there is a motion to approve those technical corrections to the handbook by Mr. Graves, seconded by Ms. Crisp. We are now on debate on the motion. Any debate or questions? Seeing none, we'll call the vote. Vote yes if you're in favor of those technical corrections. Vote no if you are not. That motion passes with 9 yes votes, and the chair will stand for a motion to adjourn. All right. With that objection, we are adjourned. If you are a member of the insurance committee, please remain in your seat.
I think so.
The commissioners are all the same.
Okay. Is this a smaller group or
Yes.
together? Just check out?
Yeah, it's a smaller group.
All right, we will call the meeting to order. We will take roll. All right, we have 5 members present. We will now have the special call of the meeting read. The Blount County Government Insurance Committee will hold a special called meeting on Wednesday, January 2nd, 2019 at 6 p.m. in room 430 of the Blount County Courthouse, Maryville, Tennessee. The purpose of the meeting will be for setting the agenda, public input on items on the agenda, approval of the minutes, specialty pharmacy vendor contract, amendment to Allegiance contract, and adjournment. We will now move on to the setting of the agenda. Again, we are removing item E on this agenda, so the chair will stand for a motion to set the agenda while removing item E. Is there a motion? Motion by Commissioner Crowe. Is there a second? Second by Commissioner Carver.
Do we not have to remove both of them? Because the other one's not a contract.
All right, Commissioner Crowe, if there are no objections, can we make the motion to remove items D and E? We can. All right, and is Commissioner, all right. Without objection, we will make that the motion. All in favor of, one moment. All right. If you are in favor of setting the agenda with the exceptions of removing item D and E, vote yes. If you are not in favor of setting the agenda as stated, vote no. All right, that motion passes with 4 yes votes. Moving on to public input on items on the agenda. Is there anyone wishing to speak on the approval of the minutes? All right, seeing none, we will go on to item C, approval of the minutes. Is there a motion to approve the minutes? Motion and a second. Moved by Commissioner Carver, seconded by Commissioner Stinnett. Any discussion? Seeing none, we will now call a vote on approval of the minutes. Vote yes if you're in favor, vote no if you're not. The motion passes. The minutes are approved with 4 yes votes. If there are no objections, we will now call an adjournment. Any objections? Seeing none, we are adjourned.